This is Wellness by Design, and I'm your host, Andrew Whitfield Cook. Today we're joined by Dr Amie Steel, a naturopath who dedicates her whole career to fostering the communication between research, clinical practice and results. And today we'll be discussing knowledge mobilisation. So I'll need an explanation of that first. Welcome to Wellness by Design, Amie. How are you?
I'm great, Andrew. Thank you very much for having me.
So I guess we really do need to start off first. What the hell is research mobilisation?
Knowledge mobilisation it's an offshoot of a area of research that's called implementation science. So I kind of need to go a little bit back in the family tree of knowledge mobilisation to help make sense of it. So it's kind of born out of the evidence-based medicine movement, which understands, was all about trying to get evidence into practice. And so and then the figures started to come out of that 15-year gap between when evidence was generated and when it actually was showing up in the realities of clinical care. And so this movement began of implementation science, and implementation science was about understanding social and behavioral economics, and what are the barriers to people implementing evidence into practice, and what do we do to actually help to make that happen? And there's a whole body of work now being done to actually start to look at how research evidence can be translated into practice and start to show up in clinical decision making. So that's their forefathers to knowledge mobilisation, but knowledge mobilisation was a bridge off from that. And knowledge mobilisation came from the view that actually research evidence isn't the only evidence or knowledge that has value. And there's a lot to be gained from, when you think about the evidence-based practice triad, you've got research evidence, clinician experience, and patient preference. That's the standard triad. And the implementation science was focused so much on bringing the research evidence in, it didn't really take into account that the clinician experience was also a form of knowledge that everyone could benefit from, including researchers, and that the patient's perspective also is a form of knowledge that can really help to support clinicians in making better decisions, but also in researchers and conducting better research. So knowledge mobilisation comes from the viewpoint that everyone actually has knowledge of value, and that the best thing that we can possibly do for the outcome for everybody is to get that knowledge moving around so that everyone has access to other people's knowledge, and then we get the best possible outcome out of it. So that's essentially what knowledge mobilisation is at a conceptual level.
There's a few things that you just tweaked in my mind there, and one is about evidence-based medicine, and people are so caught up on the RCT as being the holy grail. And there's a beautiful, it's a very old paper now, and it was a sort of whimsical dig, if you like, at EBM, and it was a double-blind placebo-controlled trial on parachute use to avoid injury. So who wants to be in the placebo arm of that one? So the double-blind placebo RCT isn't always the gold standard of what you want to do. The other one that I thought about was, you mentioned about knowledge, and I can still remember speaking to, and he was quite an orthodox doctor. He wasn't naturally inclined at all, but he said, isn't it interesting that there is still no agreed standard, if you like, of care for things like growing pains. Indeed, we need to resort to what you're talking about, knowledge. So it's like this community knowledge, really hot water bottle and things like that.
It is really interesting. And one of the things that as I've been expanding into this space is understanding some of the nuance of terminology becomes really important. So the difference between knowledge and information, for example, information being facts, knowledge being the application of those facts. So there's that. In fact, evidence-based medicine is not about knowledge; it's about information. Of course, knowledge gets documented as information, but there's the real knowledge happens in that clinical encounter. And that's when it's all about the application and the context and those kinds of things. And there's a heap of work that's being done in that space. And when I really started to understand what knowledge mobilization was all about, I thought, hang on, that's what we do. That's what naturopaths do. And so there were some really great opportunities for me to start to explore that came along. And I thought, I'm really going to I'm going to open this right up for us and for the rest of the health community to understand our position in this a lot better than a lot of the assumptions that were being made. So
right.
If I can give you an example of one of those studies. Sorry.
Yeah.
And I was just going to give you an example of one of those studies. So I was approached by the World Naturopathic Federation to produce some research for one of the bigger projects I was doing for them, the health technology assessment, which I can tell you about later if you like. But it was a large document that summarised basically everything we need to know about naturopathic practice, profession, safety, effectiveness, the whole thing. But we realised that part of the story we needed to build into that was answering that question that people are often saying is that naturopaths don't use research evidence. And so I was approached by the WNF to develop a survey to help understand how much we do use research evidence in our clinical decisions. And my response to them was, I can help prepare a survey that does that. I can conduct that study for you. But my priority, but I would just like to raise, I think we should take this from a knowledge mobilization viewpoint. We can absolutely include journals and conferences and the scientific studies as in the survey, but let's broaden our lens. Let's actually better document how naturopaths draw on and use other types of knowledge and information in their clinical decision making, because that's actually a really unique element. And in fact, we do it really well. And one of the things that came out of that survey is that we're doing it in a way that knowledge mobilizers are considering almost best practice in some ways.
Absolutely. Amie, when you're speaking about knowledge mobilization being sort of a new focus for you in your career, I think it's really important that we take our audience back to your beginnings and how you've gotten from clinical practice, well, studying to clinical practice to research, and now you're furthering that career to help others, to help the naturopaths indeed around the world, not just Australia. Can you take us through a brief journey of your career?
Sure, potted history. So I graduated as a naturopath. I was in clinical practice, and I was working as a rep for product companies, doing some teaching, clinical practice, just kind of had a real mix of things that was going on. Then I went on and did a master's in public health, and that really changed my lens. Not my philosophical approach in any way. In fact, there's a very strong alignment between public health and naturopathy, but it helped me to see things from a bigger picture. And it helped me to realize that in order for us to truly have the impact we want to have in the community, we had to figure out how best to situate ourselves in the health system, and that there's a lot of understanding of us as a profession and of a practice, and that if we focus only on the treatments, the specific treatments, on the specific herbal medicines, the specific nutrients, and doing trials on those, then we're going to build evidence for things that other people will use, and naturopathy as a profession will become diminished. So my focus, and I absolutely believe that other work needs to happen, and it has incredible value. My personal focus and mission, though, has been about understanding us as a profession and what we do as practitioners, and the contribution that we make, and the bigger picture of our clinical care that may or may not include those individual treatments, depending on what the individual patient needs, and but also will quite commonly include a myriad of different things, and comes at it from a very specific philosophical and principle-based practice approach. And so that's been my practice, my research focus up until this point in time. So after my master's in public health, I did my PhD, just understanding how complementary medicine practitioners, including naturopaths, fit within maternity care in Australia. And then that has evolved from there, and I've ended up with postdoctoral appointments. I've set up the Office of Research at Endeavour College of Natural Health, moved on. I'm now situated specifically at UTS. So I've been at UTS now for 8 or 9 years as a full-time research fellow. And in that time, I've been working very closely with the World Naturopathic Federation and other leading international and national complementary medicine professional bodies because of my focus on profession and practice rather than on specific treatments. So
Yeah,
that background has taken me to understand, to identify the bits that we really need to, the gaps we really need to fill, so we can clearly articulate what value we offer in the health system.
Yeah, okay. So let's go back to the topic then about fostering knowledge and the dissemination of that. Why is it so important to foster research in this area? I mean, I think it's a pretty obvious answer. We're being attacked left, right, and centre. But it seems to me that despite, let's say 15, 20 years of naturopathic research in this area looking at practice, that we're still under attack. And this is something that I just don't get, particularly when it's sort of like the camps that are attacking us, let's say they haven't got their own garden in order yet. If they're very well known, what is it? Was it BMJ or Lancet or New England Journal of Medicine that looked at the amount of orthodox medicine, which was actually evidence-based? And it wasn't great. I think it was something like 15%. So, there are still things that are done commonly that don't carry the weight of evidence, and yet they're blaming naturopaths for doing exactly that.
Look, I guess I step away a bit from the attacks and just like what I've done with this particular survey, which was essentially responding to an attack, and I focused on playing to our strengths. And so I think that there is a lot that naturopathy can and does do that is of incredible value. And as we mature as a profession, there's also things that we can constantly reflect back on and build on and do better on all areas, for sure. But I've just stopped engaging with the critics. I've stopped thinking about the critics. I've focused in on the profession, and I've focused on what it is that if we put the critics aside, we look at what the policymakers are trying to achieve for the health system. We're looking at what the community is asking for in the health system, and I'm looking at what we as a profession can and do offer. And then I'm just focusing on finding answers to all of those things. So as an example of how that's evolved, in I think 2017 or maybe 2016, there was a standing commission on looking at the role of primary care and chronic illness management. And so they were calling out for submissions. And they had a whole area that they had like a structure or a framework, priorities for this this call for submissions. That was all about the different elements that identified were going to be important for primary care and chronic illness, and asking us to respond to these, asking anyone who wanted to respond to these things. So I worked with one of my colleagues on behalf of NHAA to put a submission into the government. And one of the areas that's a really big priority area at a policy level for chronic illness is patient-centered care. And so that seems like a no-brainer for us as a profession. That, of course, that's one of our core philosophies, our core principles, I should say, and philosophies for that matter. But when I went to write that section, I realized I didn't have any evidence of that. We have our principles I could link back to, but I didn't actually have any evidence that we were doing it. And so I put out I proposed a project for an honours student to do that work. And I had someone who agreed to take that on, Hope Foley, and she did that for her honours. We did a very small project looking at the experience, the patient-centred care experience of patients who visited naturopaths and a few other health care professions as well. That showed very clear results. It was a validated instrument that is used for this particular type of research. And so she went on to do a PhD, and she took a bigger project. And the initial project she did was just run at one of the student clinics in the college. Her PhD project was run in community clinics in complementary medicine professions around the country. And it included chronic illness, patient-centered care instruments, as well as the complementary medicine ones we used for her PhD. That data has now got very clear. We've got 4 or 5 papers that now very clearly show that not only are naturopaths, of all of the CAM professions, the most patient-centered, They are also patients who are consulting with a naturopath and a GP rate their naturopath as more patient-centered than their GP, and that the patients who are, or the more patient-centered a patient experiences their practitioner to be, the more likely they are to disclose their use of complementary medicines or conventional medicines. We've got all this data around that now that we can take to the government and say, you want patient-centered care? We're delivering it. We're delivering it better than anybody else in the health system is delivering it. And we're delivering it to patients with chronic illness, and it's a safer outcome because they're more likely to tell us what medications they're using. It's a beneficial outcome. And so I'm moved away from paying attention to the detractors because, to be perfectly honest, for a lot of those people, they are not science-based in their attacks because their attacks are not based on their own evidence. And so I just don't see the point in engaging with those people. I'm focusing on what are the solutions that the government are looking for and which of those solutions are we actually the solution to. And building out that evidence so we can make a compelling argument.
Yeah, a couple of things you said there about patient-centered care, and you know, it really does seem that orthodox medicine, at least in Australia, that's all I can speak of, is can't be focused on patient-centered care because it is too focused on time, and there's a time, money, care triad that has to happen there. One has to lose out all the time. So. Anyway, so there was a very interesting article written by a GP who actually tried to address this time versus care conundrum. And she decided to ask every patient that day, is there anything else? Is there anything else? Is there anything else? And when she timed it, each consult was only 2 minutes longer. Now, add that up over a week and you do have a significant time. But for each patient, that could be anything from liking your GP to life-saving in the information that you glean from that extra question. And this indeed is what you say, is that one of the reasons people like to see naturopaths is because they feel they're being heard.
Yep. One of the other things that came out of that study, though, which kind of links back to this idea of knowledge mobilization, is that they felt empowered. They were given information that they could then use to look after themselves and identify when they needed extra care. And they actually came away with a sense of empowerment that they had some control and influence in their own health outcomes. And that part of that was our, again, coming back to our principles, our focus on doctor as teacher, that we are all about educating people and giving them the information they need to look after themselves.
So what sort of topics specifically are we talking about with regards to knowledge mobilization? There's a few things that spring to mind with me, and that is things like vitamin D, the importance of vitamin D, vitamin K2 as opposed to vitamin K being a single entity, fish and fish oil. You know, the work by Dyson was basically championed by natural medicine and laughed at by orthodox medicine until the GISI-P and the GISI-HF trials and the DART trial and things like that, which are massive trials piggybacked onto usually statin or other heart medication parameters, sorry. But also things like looking further into cholesterol. Actually, I should catch myself there, looking further into lipoproteins, not cholesterol, because we get caught up on an erroneous term, things like that. So what other topics are you sort of championing here?
Well, my kind of the researcher brain in me is like, well, we just need to, all of these things that you've just said are all true. And we know we don't have any empirical information about that. We don't actually it needs to be better documented. And so the survey that we did of, another survey that we ran in addition to the knowledge mobilization survey is one on the community education and health promotion activities that naturopaths undertook. And the sorts of topics that they were talking about were about just how to prevent illness, how to self-care, how to manage health complaints, at a very high level topic kind of areas about the naturopathic principles and approach, those kinds of things. And so I think because we are so individualized, all of those topics are that you mentioned are absolutely likely to be in the mix, but they will vary completely depending on the individual patient that's in there. But the different are kind of separate to that, because the sort of work you're talking about is also their contribution to building new knowledge. So one of my PhD students at the moment is looking at how different forms of folate and changing the form of folate can actually have real differences, particularly in women with MTHFR polymorphisms who've had recurrent pregnancy loss. So this is actually going to be a really confronting conversation for the public health community. It's challenging very established, very accepted norms around folic acid fortification and supplementation and all sorts of things. It's a very brave step to be taking in a public health space to be doing it, but it's important work, and her honours research has indicated that there is justification for that work to happen. And so I'm supporting her as a supervisor to actually make sure that we build the argument in such a robust way that people might find it confronting, but they can't dismiss it out of hand. And so,
indeed it was confronting to me, because I was one of that old guard that just thought, we've always used folic acid. What's the problem? No. Carolyn really opened my eyes and slapped me around the face a little bit about this unmetabolized folic acid. This is such an interesting area. And it's not a countering of that, but there's also things that we need to change in our own vernacular and leave behind because we've got them wrong. There was a nice term, for instance, called leaky gut syndrome. And again, one of your colleagues, Brad Leach, has basically dissed that. It's not a syndrome. It's kind of like saying you've got a pain syndrome. No, you've got pain. You've got leaky gut or hyperpermeability. But permeability happens all the time. It's normal. So he's really sort of fine-tuning what we should be saying as our vernacular rather than these nice terms that were made up. The other one that I was thinking about was the concept about folic acid with cardiovascular disease. Great for prevention and possibly very good to stop ongoing damage, but damage that has already happened can't reverse. It's kind of like, I think this was stable or unstable angina. And what they were talking about was that giving more folic acid in these patients doesn't help. It's kind of like asking a folic acid supplement to heal a cleft palate in a baby that's been born where they've already got the neural tube defect. The horse has bolted in that instance. So it's really, it can be, as you say, confronting to both sides, if you like. But what I'm so impressed about is, you go, sorry.
No, I was going to say, one of the things that comes from that then is that on that topic of clarifying the vernacular, there is the research centre, Arkham, that I'm a part of, we run a leadership program for naturopathic, an international naturopathic leadership program for researchers. And so there's 12 of the leading naturopathic researchers, and we bring them together when we're not in a pandemic once a year, and we do a lot of collaborations and things like that. So one of the fellows is Dr. Ryan Bradley from National University of Natural Medicine in Portland and the Health Gut Research Institute. And so he led a paper with other fellows from that program on naturopathy as a disruptive innovation in healthcare. And one of the kind of really great points that he was making in that is that we are early adopters. We take on this new knowledge, the lipoprotein research, the folic acid research, the leaky gut research. We as soon as this stuff is coming out, we're paying attention and we're starting to think about what does this mean for our patients and how do we apply it, and which is really great. It's a really great characteristics of our profession. But we also need to be aware that because this knowledge or this evidence is still emerging, we have to be very ready to adapt and modify our practices and our approaches when what we thought we first understood when that first bit of information came out it becomes clarified with more research and more evidence. And so it is a case of us being open to being flexible around
Yeah.
that new knowledge, because we are early adopters of research evidence. We do take things on. It doesn't take 15 years for research to get into naturopathic practice at all. We can be really quite proactive in terms of applying new evidence as it arises.
Detractors, I know you don't engage with them anymore, that's great, but detractors of natural medicine will often say, oh yeah, but sometimes you jump the gun with evidence, like for instance that folic acid with cardiovascular disease, and they go, see, it didn't work, it didn't pan out. We'll say, well, hang on, what about Vioxx? What about thalidomide? What about arthroscopy, knee arthroscopy? So there's all of these. They're not just drugs. So it's not. You can't just blame the pharmaceutical industry. They're interventions. They're medical interventions that they were accepted. What was the other one? Paracetamol for lower back pain. How many decades was that in the guidelines for? And now it's not. So the world turns. I just think it's really interesting that there's so many people. Yeah, really ready and willing to heap blame upon natural medicine without sort of keeping their own house in order first. I was going to ask, oh, that's right, forgive me. I was going to just put this in because this is really interesting to me about the journey that orthodox medicine, it's been this sort of toing and froing all the time with vitamin E. I can still remember the journey about, it's got to be natural vitamin E, the D alpha tocopherol, can't be the DL. And then it was blaming the DLs. But then there was also this sort of smouldering side bit of research that has now come to the fore about the tocotrienols, possibly being probably the major active component. Yeah. And the problem was that we left them behind when we purified it too much. So now we're sort of swapping over to the tocotrienols rather than the tocopherols. It's really interesting how the world turns.
It is. And that really reminds me, though, that one of the things that when we've got naturopaths doing that research, because you're saying that we were doing this, we were doing that. It wasn't actually naturopaths doing any of that research, that refined vitamin E research. And that's actually not how naturopaths practice or think. And what we found when we started bringing together for the health technology assessment, all of the clinical research that's been conducted by naturopaths, there's over 300 studies, there was hardly any that were just one intervention, hardly any. All right, most of them had, even if it was a herbal formula, it had 2 or 3 herbs in it. If it was a vitamin formula, it would be 3 or 4 vitamins. Very commonly, you would have 2 or 3 things, like you have some herbs and some vitamins and maybe some lifestyle or a hydrotherapy intervention. They're really quite, we practice in complex ways, we think in complex ways, and we research in complex ways. And I would say that if a naturopath had started asking questions about vitamin E, we would never even had the problem that arose, because we would never have taken that approach of refining it down to a natural versus synthetic and getting into the nitty-gritties of all of that. Now, I fully believe that mechanistic research is incredibly valuable, because it helps us to know how what we are using works. But in terms of clinical interventions, just using one intervention, we know that that's not how the human body works. And in fact, one of my other PhD students, Kim Graham, is doing some amazing work on complexity science and looking at how naturopaths think in that incredibly complex ways, and that the human system is a complex adaptive system. It's not a reductionistic system. And again, this is not rocket science from a naturopath's point of view. We know this. That's just how we think. But there is now good scientific, rigorous methods that have been used in ecology research and internet research and all sorts of things that she's bringing across into health as a way of actually helping to understand how we can think about these things. They've started using some of that in Chinese herbal medicine research. They're using network meta-analyses, where they're starting to look at the herbs that are most commonly coming together in these original formulas and trying to get an idea of like the most ideal mix of herbal medicines, and they're using it from that point of view. But I think taking that step back again, which is the work that Kim's doing, and saying we need to think about this not just in terms of the intervention, but of the human body. And so if someone presents, in the case that she's using for her PhD, she's just written up her first paper on this. If the case presents as someone with obesity, then We are very conscious that obesity is not just about diet. We're looking at hormones. We're looking at mental health. We're looking at inflammatory markers. We're looking at all sorts of factors that play into that. And so if you're treating someone with obesity, you're not just going to give them chromium. It's just not how this is going to roll in a naturopathic intervention. You're going to look at all of those things and try and support them on all of those levels. And I think that complexity is one of the things that has led people to think that the RCT model doesn't work for naturopathy. But that's a separate conversation.
I've got to say, I'm so impressed with the way that your mind is thinking about the complications and the nuances of caring for a patient, not just delivering uphill. And I do feel, I know I sort of seem to be doctor slapping at the moment, but it does seem to me that there is this, more and more there seems to be this one pill approach or one therapy approach for a condition rather than the older doctor. Forgive me, I love his name, Dr. Winkworth. I mean, it's just a cracker. When I was a kid, and Dr. Winkworth would never just give one pill. He'd always say, there's the hot water bottle, or, the compress, and there's, the warm shower for a fever. And all of these very simple home remedies, if you like, that were not harmful, and they may aid in helping the major therapy that he was prescribing, so whether that be antibiotics or a pain medication, whatever. But to me, he always, I don't know why he's always stuck in my mind, but he fostered what medicine was truly about. And it just seems that naturopaths have taken this because they've remembered the old ways. So they've actually taken this and remembered that it's care. Care is not one pill, one thing, but it's a whole host of things which we're talking about. And oftentimes the dissemination of knowledge, as you say, so that patients can be empowered to look after themselves. Who would have thunk? Yeah.
Well, I think one of the things as well is that it's almost become so far down that track for doctors that unpicking that's going to be really hard. Not impossible, but really hard. Because now when you talk about multiple treatments in medical care, that it's the first thing that they're going to talk about is polypharmacy. So it's not one, if it's not one pill, it must be 3 or 4 pills. And it's not that other mix. And that creates all sorts of problems. So rather than seeing it as, it's complicated. The human body is complicated, and the patients who show up in clinic are living in a complicated world, and everything that we do needs to kind of hit them on multiple levels and support them in numerous ways. And that takes a certain way of thinking. You have to hold a lot in your brain when you're providing care to people in those situations. And absolutely, the supplements and the herbal medicines are really important. And they equally important is the diet and the lifestyle. And the research that we've done for the World Naturopathic Federation is that internationally, dietary interventions and lifestyle prescriptions are the 2 most common therapeutic interventions that naturopaths are using, followed by herbal medicine and nutritional supplements. But dietary interventions and lifestyle change are the 2 most common things. Yeah. So they are the cornerstone of naturopathic practice that are very well supported by herbal and nutritional medicine. But herbal and nutritional medicine are not as prominent at all.
The good naturopath is always mindful that supplements are not mainements. The mainements are diet, lifestyle, exercise, mindfulness, blah, blah, blah. Just on that polypharmacy, I'm going to do it again. And I have to, because it's true. It happens so often. How many times, and forgive our audience overseas, but in Australia, there's this setup where if a pensioner pays for, I think it's 52 scripts, by the end of 52 prescriptions, then you get on what's called the free list for that year. And then your prescriptions are given to you at a much cheaper rate, if any charge at all. So I can still remember when I worked in pharmacy that a woman reached the free list by the end of February. That is
Man.
26 prescriptions per month. And she had her prescriptions in a long Tupperware cake box, a long, thin one with handles. I'll always remember it. It was like the sort of Christmas cake thing. And when I looked at it, several of the subsequent medications were designed to alleviate a side effect of a previous medication. And despite the chagrin of her treating doctor, I implored this patient to go and see a physician. Dr. Quinn, if you're out there, I honour you, sir. This doctor put her into hospital. She came out a week later on 4 prescriptions. Polypharmacy,
Great.
anyone?
Yeah.
So,
And the thing is, like, I can remember when I was in clinical practice, you get complex patients too, right? We are not getting the patients who've just got recurrent colds, or actually we do get patients who've got recurrent colds as well. But those patients who've got allergies and heartburn and insomnia and all these things are quite likely interrelated, but patients are still coming at it from an perspective of, great, we're treating this now, but what about that? And what about this? And so it takes a certain amount of skill as a clinician to help the patient navigate their way through not fixing everything at once. And there's a lot of education that comes with that as well. And that's coming back to that idea of us as knowledge mobilizers and educators, and empowering patients to better understand their own health, is to help them understand that, yes, I understand that's still a problem, but we really need to focus on this first. And if I give you things for that, you're now going to be taking 6 different things, and that's actually quite a lot to be taking all at once. And we not really going to know which one's working. And there's also a lot of extra time. That takes time to counsel your patient through those expectations. Particularly if they're like, I would prefer to take something than to change my diet. And there's again that education, support, counselling, addressing that from a motivational counselling point of view. There's a lot of change that a lot of extra work for us, whereas prescribing something extra isn't extra work for us in that way. And so I can understand how those things come about, but I don't think they should. I could just understand how they could.
Yeah.
So, yeah.
Amie, there's so much more to discuss here. It's a huge topic, but something that we can learn something from as we move forward, from your research and your colleagues as well. And forgive my audience for sort of doctor slamming, but I cannot ignore it, as you do, Amie, and you just move forward and concentrate on what you're good at. But I cannot ignore this inequity when we're talking about patient care, that naturopaths are delivering, and they're being detracted from and attacked by certain facets. And I do apologise to the doctors, particularly my GP, who is quite orthodox, and she's a brilliant GP. She's a true doctor. So please accept my apology for the doctor slamming I gave, but I think it's an important sort of topic to sort of discuss if we're going to be really honest with ourselves. Amie Steel, thank you so much for sharing this today.
That's okay. I understand, and I know some awesome GPs as well. And on that thing of patient experiences as well, I just want to bring back that last point, if you don't mind me having one last point, is that patients, going back to the evidence-based medicine triad that we started with, that triad starts with patient preferences. And one of the things that we found from our research is naturopaths aren't just using patient preferences to inform their clinical care, which is essentially, I don't like that liquid, can I have it in a tablet form? It's actually, we focus on, we actually use patient experiences and listen to those experiences of their health as a form of knowledge. And we value that. And that is not showing up in other areas of the health system. We will take that patient's telling of, I find that when I eat this type of food before bed, I have really poor sleep. We don't dismiss that. We actually genuinely engage with it, take it on board, consider it in our larger clinical understanding of their case. We value patient experiences and understandings of their own health. And that's also part of what makes us amazing knowledge mobilizers. We listen to the research, we listen to our patients, we share our own clinical experience and knowledge. We bring all of that information together. We share it back with the patients. We share it back with the community. We are incredibly important in synthesizing and sharing the health information out there. And that's one of our strengths that we really need to be really proud of, because it's something that helps us try to figure out how to do, and we can just show them how we do it.
Well done, Dr. Amie Steel. Thank you so much for sharing this. You are obviously, I mean, it just shines from you how you are dedicated not just to your colleagues in helping the profession reach the heights that it really should be honoured with, if you like. I'm saying that word too much, but that we've really earned our stripes, but also the care that this means for patients by your colleagues delivering excellent care to them. Thank you so much for joining us on Wellness by Designs today.
Thanks, Andrew.
And thank you for joining us. Remember, you can catch up on all the other podcasts and the show notes for this podcast on the Designs for Health website. I'm Andrew Whitfield Cook. This is Wellness by Designs.